Good evening, everybody. Welcome to our PHN Immunisation update for 2023. My name's Kira Wright and I'm the Immunisation Team Leader here at Central and Eastern Sydney PHN. Also joining us from the PHN is our Immunisation Program Officers, Brooke Willoughby-Thomas and Mimi Campbell. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. Tonight for me, that's the Dharawal people of the Eora Nation. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. Sovereignty has never been ceded, it always was and always will be Aboriginal land. I also extend that respect to Aboriginal colleagues joining us tonight. Just a bit of housekeeping. We have the Q&A function working tonight. So as questions come to mind, or if you wish to wait to the end of a presentation, please put your questions into the Q&A and then we will answer them after the end of each presentation. Please note this webinar is being recorded and will be available on our YouTube in coming days. And at the end of the event, we will have an evaluation survey pop up in your screens. We appreciate your feedback, so please complete this to allow us to issue certificates of attendance and welcome your suggestions for future webinars. First up, I'm going to go next, Brooke. We just have some care finders and healthy aging hubs. So just to let you know, the PHN is commissioning some healthy aging hubs in our region. So there's one opening in Gymea right now. And for more information, please see our website. Some upcoming events for you to put in your calendars. And if you'd like to register, please register online. Tonight, our agenda is full packed. So we'll get started. Jump right in. We've got Anna McGlynn from the Health Pathways team, just to give us a quick overview of Health Pathways and remind you all to use it. Thank you, Anna.
Thanks, Kira. I'll quickly share my screen. So yeah, as Kira was saying, I'm just reminding you about Health Pathways, that they're for you, supporting your care all the time. We've got 2 QR codes here. So if you don't have Health Pathways access yet, scan that or use the URLs and the South East Sydney Health Pathways and Sydney Health Pathways. You're going to be using the Health Pathways based on where your patient will be accessing care, and that's to make sure that you get all the location-specific information. On South East Sydney Health Pathways, we've got lots of pathways around immunisation, and they have been updated with the influenza changes. And then there's also a lot of other ones about some interesting things you'll be hearing about later this afternoon, no doubt. And same for Sydney, a whole heap of immunisation pathways and lots of infectious diseases that might be of interest. And we've got our contact details. So if you want to get in touch with the team, you've got any feedback or anything like that, you've got all our contact details there, and you can also get them off the PHN. Thank you very much. That's it from me.
Thank you, Anna. That was great to remind everybody to use Health Pathways. It's a great tool, and we'll be providing the slides after the webinar as well. So all those contact details will be provided to you. Next up is just a quick update from me. So I just wanted to give you a quick snapshot of where we are with COVID hospitalisations in New South Wales, just to remind you all that, COVID's still around. And yeah, as you can see, there's, still people in hospital, still people dying from COVID. So it's really important to promote those booster vaccinations. And then, yep, next slide. We just want to give you a quick snapshot as well of what the coverage rates are like within our LGAs. So I know it's a bit hard to see on the screen, but this is the adults for their dose 3 for the over 16 population in the blue, and then the dose 4 for the eligible over 30s in the orange. So those booster vaccinations are not as high as they could be. So a reminder to just keep that in forefront of your mind when you're seeing your patients. Next slide. We also have the coverage for the children. So again, it's not as high as we'd like for the 5 to 15-year-old children. So just, again, keeping it in mind to reach out to the children within your patient cohorts. And later on, we will be showing you how you can identify those children that are due for boosters and doses. Just from the general practice perspective, the general practices out there continue to support the COVID-19 program, and we thank you for that. And if you have excess stock or you need more stock of specific vaccines, always contact us because we've got a bit of a sheet of, who has vaccines available, so we can facilitate that transfer. Pulse oximeters, we also are providing those still. So if you have individual patients that need them, we have a small supply, and you can fill out the form if you'd like, and we'll provide these links afterwards as well. And then for general practices who are seeing patients of moderate risk, you can get up to 10 pulse oximeters delivered to your practice. Our Vax at Home service is still doing great work as well. So we continue to support the vulnerable populations, and that's for housebound patients 16 years and older. They need a GP referral or the LHD referral, and that can be sent through via the online form, which is also available on our website. Aged care, we've been asked by the Department of Health and Ageing to ensure that there is access to a primary care provider for that COVID-19 booster vaccine. So if you have patients in disability group home or residential aged care facilities, and you as a provider can't go out yourself to vaccinate those patients, you can also contact us to organise a group vaccination. This was announced last week, and the closing date is next Tuesday, so after the Easter break, and we encourage you all to apply if you're a general practice with a practice nurse employed. We're offering $2,000 to deliver a nurse winter vaccination program. So it's just about identifying those patients due for COVID boosters and other vaccines that they may be eligible for, and following them up, doing active outreach to have a chat to them, bring them into the clinic for a vaccine, or even just for a conversation about the vaccine. So please apply via our website. Just a reminder as well about the pharmacist immunisers out there. They're doing a great job along with general practice. They have completed the accredited vaccination training course. They have to notify AIR just as anybody does, and they conduct vaccinations under the New South Wales pharmacist standards. So if you just go to the next page, just a reminder of, again, it's quite small, but we'll provide the slides, just a reminder of what the pharmacist immunisers can immunise for, and they have access to NIP vaccinations as well. So they're supporting vaccination for everybody out there, just like the general practice are. Lastly, if you need immunisation assistance, we can help with cold chain management, NIP, childhood overdue reports, COVID-19 vaccine transfers, and we have a wealth of information on our website. Every link related to immunisation we have there in some space or another, but if you need help navigating it, please just email or call us. All right, that's it for me. Next up, we have Professor Nicholas Wood. He is the Associate Director of Clinical Research and Services for the National Centre for Immunisation Research and Surveillance. He's a Staff Specialist General Paediatrician and Professor in the discipline of Child and Adolescent Health at the University of Sydney. Nick leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital at Westmead. He's a Senior Investigator on the Primary Health Network Immunisation Support Program, which supports us and all the PHNs around Australia a lot. So thank you, Nick.
Oh, thanks, Kira, and hello, everyone. Great to be with you all. Just to acknowledge country as well, and lovely artwork here, which you'll get when you get the slides, a chance to have a look in detail at the words that describe the meaning of the art. So what we're going to do tonight is cover these sort of 5 topics: influenza, COVID, where we're at with the COVID, a little bit on RSV, a new DTP combination vaccine called Vaxelis, and a little bit on the Immunisation Specialist Service. Starting off with influenza, this is the information that we know from the Northern Hemisphere. And you can sort of see that towards sort of the end of 21, early 22, there was this unusual double bump, but not a big year. In the winter that has just passed in the Northern Hemisphere, you can see that It was mainly a flu A season, a little bit of B, but interestingly no B Yamagata, and it probably came a little bit earlier than they were expecting. So that's the Northern Hemisphere end of last year and beginning of this year. This is the Canadian story, the usual pattern with the sort of grey there, peaking around about February, again a little bit earlier, the 2022-23 season that just passed, and a reasonably big compared to that sort of outlier, which is the dotted line down the bottom, which was the 21-22, where it was sort of very much out of season, and that's mainly because of all the efforts that were being done to control COVID that were actually limiting the spread of flu. This is a little bit on the Southern Hemisphere. In the end of 22, there was a bit of an out sort of in the South American countries. Again, interestingly, no B Yamagata. So it appears that perhaps B Yamagata might have disappeared. This is the Australian story of 2022 in the red, and you can see that it came early, started to rise in around about now in early April, and was pretty much gone by sort of mid-August, late August, and in contrast to 2017 and 2019, where the onset was a little bit later. So what does that mean for this year? Time will tell, but I'll show you a graph in the minute, which might suggest that the flu sort of starting to tick up. This is the number of admissions. Hospitalizations is obviously a marker of more severe disease, and again the red line showing 2022 a little bit earlier compared to 17 and 19, but not as bad as 2017 in terms of hospitalizations. In terms of rates of influenza, this is showing you the rates by age, and it's the usual story. Most of the disease is in the younger kids, the under 5s, and as we know, there's the free program for the 6 months to 5-year-olds, and then the over sort of 70s. Although the rate is lower than the younger kids, they're the ones that often end up with more severe disease. So that was a story last year. This is a really nice report that comes out from New South Wales Health on a regular basis. The top part of the report's about COVID, and the bottom part actually starts to talk about flu and other viruses as well, actually. But what you can see here is that there's a slight increase in testing and positivity in the flu cases towards sort of March and the end of March and in the weeks just past. So whether that means that the flu season is starting to tick up, again, time will tell, but the vaccines are available. And so the usual question of, should I get the vaccine now or wait till later in the season? I think it's probably just, if someone turns up wanting the flu vaccine now, then they should just get it. So how did we do with coverage last year with flu? And on the left panel here, you can see all people. And what we do each year, which is sort of replicated in 2022, was we do okay in the over 65s, not so well in the younger kids, the 6 months to 5 years, for whom it's free, we got to about the 30% mark. And on the right panel shows the coverage in Aboriginal and Torres Strait Islander people, and a little bit lower again in that 6 months to 5-year-old age group, but not on par for the over 65s. What is pleasing is that most of the uptake is in that the steepness of the slope is in the sort of April-May period, which means that the vaccine is being getting in towards the beginning of the season, which is when you want it to get in to give you some protection. So how well does the vaccine work? And so it is monitored each year, and Alan Cheng leads a group called FluCan, and they collect data from the hospitals to look at how effective the flu vaccines is. And so the bottom line was that the 2022 flu vaccine was around about 50% protective against hospitalisation. And what you can see from the graph there is that it really didn't change too much between the sort of under 16s and the over 65s. It was still in that sort of 45 to sort of 60% mark. Some years it varies quite widely, but around about 50% protective. And in terms of protection against flu A, H1N1, it was a little bit better at 60 to 70%. So if that was the question that someone might ask, well, how flu vaccine doesn't really work, and you can say, well, last year was about 50% protective against hospitalisation, which is not too bad. So this is the strains that are in the flu vaccine for this year. As you can see, there's 2 A's and 2 B's. There is a new strain of that flu A Sydney in there, but they're the strains that are in the vaccine for this year, 2 A's and 2 B's, which is what has been the last few years. So here's the recommendations, which you pretty much know, and just to repeat them, it is recommended for everyone over the age of 6 months. Administer before the onset, and like I showed you just in the graph gone past, it probably is the time to start getting the vaccine in, and that's why that nice nurse winter program, which we just heard about, is a good way to hopefully get the flu vaccines in. The protection is highest and lasts about 3 to 4 months. It can be given with other vaccines such as COVID-19 vaccines. If someone wants the Fluad Quad, which is the older population, so that's adjuvanted vaccine, and Shingrix, the recommendation is that they ideally could separate by a few days, but if that's not possible, it can still be given. It's mainly a side effect type profile because they both can give you some systemic side effects. If the person had a 2020 flu vaccine in late 2022, then they should still get the 2023 vaccine. And as we know, it's available now. So what's it funded for? All kids aged 6 months to 5 years, Aboriginal and Torres Strait Islander people. And then the table here, which we won't go into detail, but anyone who has a chronic medical condition, and that's outlined in the handbook, and pregnant women. And the goal there is not only to protect the pregnant woman during the flu season, but because of the passive transfer of antibody to the baby, can protect that infant for the first 6 months as well. This is a table which shows you the vaccines and by age, and the white boxes are the ones that indicate that it's free under the NIP. You can see that in the over 65, the NIP vaccine is Fluad Quad. But the other one that can be used in the over 65s is the high zone, flu zone high dose. The difference with that one to the Fluad Quad is that it just has a larger amount of flu antigen in it. Though both of them are okay to be giving in the over 65s. So the US, how did the US fare in their season just gone? And again, as I showed you before, the 2022 flu vaccine effectiveness, this is the Northern Hemisphere early estimates from their program. And you can see that the effectiveness was around about sort of that 50 to 60% mark again. So hopefully it'll be similar in Australia. So that's the sort of summary on that one so far, but more data will come from the Northern Hemisphere. We often get asked a question which is sort of based on this here, the Flucelvax versus the other standard vaccines. There is an assessment which is being sort of looked at on the vaccine effectiveness and the safety of both of those. But right now, ATAGI is saying that both vaccines have similar efficacy and effectiveness. Some information there you can see on the website of NCRS, where you can have a look at the flu data. So here's some of the usual questions that we get asked. Can those who have a latex allergy get the flu vaccine? And the answer to that is yes. All vaccines on the NIP are latex free. What about someone who's egg anaphylactic? Yes, you can get the flu vaccine with no problems. Co-administration, yes, although I did mention before that Shingrix and Fluquad, ideally separate that by a few days. We don't really recommend a repeat flu vaccine throughout the season. If, however, someone was travelling to the Northern Hemisphere, perhaps at the end of the year, and they wanted to boost their flu, then they could have another dose then. And like I said, the woman who was pregnant, who may have had a flu vaccine toward the end of last year, should still get the 2023 one. And in those sort of rare cases, if someone does have Guillain-Barré syndrome, there's a nice algorithm which is on that link on Ausvac Safety to help guide you on what to do for them. So here's a bit of a poll. It's a little bit cheeky because we haven't talked to you about the COVID vaccine yet, but so this Mrs. Smith is 25 weeks pregnant, and the poll's popped up onto the screen here. She's rubella non-immune. She last had her Boostrix, the DTPA vaccine 3 years ago, and she had a recent COVID infection, which was PCR positive around about 2 months ago. So the question is, which vaccines would you recommend for Mrs. Smith? We've got 4 choices there: flu and a pertussis-containing vaccine, flu, pertussis containing vaccine and a COVID, or flu, pertussis containing COVID and a rubella vaccine. So I'll give you a chance to try and vote for those. Excellent. Okay, so the correct answer is influenza and pertussis, and that's what most of you got, which was great. We don't want to give a rubella vaccine to it's a live viral vaccine, so we certainly don't want to give that to anyone that is pregnant. And the COVID vaccine I'll talk about in a minute. It is a little bit confusing, but the COVID vaccine recommendations for pregnant women, I'll talk to you in a minute. So yes, influenza and pertussis are the correct vaccines to be given, and the pertussis containing vaccine. Okay. So in terms of safety, Ausvac Safety will again look closely at the 2023 vaccine. This is the safety profile from last year, and encourage you to have a look on the website as the rollout commences, where we'll update it on a very regular basis. We had data from about 160,000 people completing surveys last year, and this is the safety data from the kids. You can see the usual side effects of local reaction, some fatigue, and the fever rate was about 10%. So that's sort of within the ballpark of each year's flu vaccine with kids. It's sort of in that 6 to 12% mark. In terms of pregnant women, you can see not many surveys, but usual side effects again of local reaction, fatigue, headache, muscle and joint pain. So what you can do if people come in a little bit later and wondering about the safety of the 2023 flu vaccine is you can go on to the Ausvac Safety website, and these sort of graphics will be available as soon as we get enough data, and you can show them in fairly near real time how the 2023 vaccines perform. So the key messages, it is recommended for kids, as we mentioned, anyone over the age of 6 months. Co-administration is one or more vaccines is safe. The other, consider when someone comes into your clinic and it's winter time, consider other vaccines. And I think, you know, one idea is to think about is do winter well. And then you might think about a flu vaccine, a pneumococcal vaccine. Do they need a COVID booster? And think about other members of the family. And most importantly, as you're all doing anyway, put the vaccines on the air. All right, so moving on to the COVID story. Kira's showed you some data. It's certainly the burden is lower than it was, say, in the beginning of 2022. And we're probably moving into more of an endemic stage. Most of the variants are the Omicron, and usually about a third of them are the XBB recombinant variant. So that seems to be becoming the dominant Omicron subvariant. This is sort of the data which was gained on that lovely New South Wales Health report. you can see from January till sort of middle March, the testing positivity with both PCR and rats, and fairly stable and lower than it was at the end of last year. ATAGI has put out quite a nice graphic just as of a couple of weeks ago. And this really summarises the booster recommendation. So starting on the left, you can see in the under 5-year-olds, no booster is recommended. Going to the far right, over 65s, ATAGI does recommend you get a booster dose. If it's been 6 months or more since your last COVID vaccine dose or confirmed infection. And then in the middle, between 5 to 64-year-olds, it really boils down as to whether or not you have severe risk factors, and that's that sort of chronic medical group. If you do have severe medical risk factors and you're 18 to 64, then you should get a booster dose. If you're 5 to 17 and you do have risk factors, then it's basically the idea to chat with the GP or the healthcare provider. So that's the sort of overall summary. That takes into account what we know about the burden of disease. And like I showed you before, there's PCRs and rats, but you know, people might be doing a rat that's positive and not actually recording it, so we don't really ever count it. But the other way to look at the burden of disease is to do seroprevalence studies. So NCRS has been coordinating these studies across 4 states by taking blood at the point of blood donation from those that turn up to the Red Cross services. And you can see there were 3 survey time points that we did: the first quarter of 2022, the middle of 2022, and the last quarter, and there's a new one about to come out as well. The grey shows the early years, and the black shows the most recent one, although this will be supplemented, as I said, by a newer one. And what you can see pretty much is in all ages, the seroprevalence went up. So between sort of the ages of 18 to 60, blood testing is suggesting that anywhere between 60 to 80% of us have already had COVID. So that's an enormous population level, you know, immunity. So that is important because that feeds into the questions about a booster dose. So I showed you before, the under 5s are easy, no booster. The over 65s are easy because you do get a booster if it's been more than 6 months. But between the 18 to 64s, there's that lovely word consider. And so just to dive a bit more into that, these are the sorts of questions that the 18 to 64-year-olds who are well might ask you. So, you know, I want to reduce my chances of going to hospital. So the fact that people have had past infection and probably 2 previous doses, and for some 3 previous doses, is a pretty good hybrid immunity and pretty good protector against severe disease. So a booster to them only offers modest increase in protection. I don't want to get sick for my travel plans. I want to get sick because my wedding or my travel plans. The vaccines won't really stop you from getting the booster dose, won't stop you from getting infected, but they might sort of stop you from getting severely infected. And then the last one is I don't want to pass anything on. Well, what we know is that the vaccines aren't brilliant in stopping the ability to transmit infection. So you can still get infected, you can still transmit, but you won't get too sick with it. So if that's the reason they want to get a booster dose, it's probably not going to be make much of a practical difference. However, if you're 63 and you've got a bit of hypertension and maybe a past history of asthma or something, then you probably could, get a booster dose if it's been more than 6 months. But if you're 62 and you've had 3 doses and real COVID, you've probably got pretty good hybrid immunity, and so a booster dose may not be that, relevant, may not make a major difference to you. So it is still quite tricky to message. In terms of what we know about hybrid immunity, this is a busy slide, but I'll just quickly walk you through it. So really looking at the top 3 graphs. So the first one on the left is previous infection. And what it is the line is sort of time since previous infection and how well the protection lasts. And so if you have had previous natural infection, you can see that you still do get some protection out to that sort of 12-month mark. The line's pretty flat. If you look at panel B, which is a hybrid immunity, those people that have had a primary series and had natural infection, you can see that the primary series is also holding out pretty well. So that's 6 to sort of 8-month mark. So against hospital admission. And the added benefit of a booster dose is sort of not much different to those that have just got hybrid immunity from the primary series. So that's what's fed into ATAGI's recommendations, that in the context of a community where there's a significant amount of us have already had natural infection, plus a large amount of us have already had 2 doses, the hybrid immunity probably does give you reasonable protection. These are a nice graphic from the Commonwealth Health Department showing you the different COVID vaccines. These are a little bit old now because the game now is the bivalent vaccines. And again, it's a little bit tricky because there's 2 types of bivalent vaccines. There's the BA1 and there's the BA.4/5. BA.4/5 is the strain of Omicron that's sort of circulating. So Pfizer has a product and Moderna has a product. Moderna's advantage from a market perspective is that when it comes, it does actually come in a pre-filled syringe. So that's a bit easier. And you can see that the booster dose interval for both the BA.4/5 for Pfizer and Moderna is at 6 months or more since your last COVID infection or vaccine. We don't really worry so much about how many previous doses you've had. So someone that's had 3 previous doses, we treat just the same as someone that's had 2 or 4 previous doses, as long as it's been 6 months or more since their last dose. So a couple of the questions that we do get asked from previous webinars, and we've tried to answer them now for you guys, is what about healthcare workers? The NCS is just about to put out an FAQ on this one. And the bottom line is that they probably treat them, we treat them just the same as anyone else aged 18 to 64 years who is not a healthcare worker. So if that healthcare worker does have medical comorbidities, then they should certainly get a booster dose. If they don't, then you do need to discuss with your GP your individual situation. And we talked a bit about some of those questions earlier. And what about during pregnancy? Again, the same sort of answer. If that pregnant woman does have medical comorbidities, then they should. But the sort of thinking is it's the same as any 18 to 64-year-old who doesn't have medical comorbidities. They can just talk to their GP about it. The World Health Organization SAGE group is going to put out some guidance quite soon, and we'll see if that matches with what the ATAGI has suggested. So the stronger evidence says that booster doses are particularly protective for those over the age of 65. ATAGI has made this judgment call that those under the age of 65 who don't have medical risk factors may not gain a significant benefit, but they can consider it. And we're weighing up particularly the risk of severe disease and the risk of the vaccine. The data from the booster doses of COVID in the younger 18 to sort of 40-year-olds suggests that there's no massive increase in myocarditis or pericarditis. However, there still are some cases being reported. So I suppose the summary is there's small benefits and small risks, and it's up to how your individual person wants to proceed. In terms of RSV, just moving on to a completely different virus. This is the reason we bring this up is that it might well, be the next vaccine that comes into the community. Possibly not this year, but might not be too far behind that. Virus V is certainly a respiratory virus that causes runny nose, cough, fever, wheezing, difficulty breathing. Unfortunately, there's no specific treatment. Now we can just manage the kids symptomatically. It is notifiable, so it does. Cases are being picked up through the notifiable diseases surveillance system. These are the burden is really highest in the under 2s, And although there is some burden in the over 65s, and what this shows you on the right, those graphs is panel A, panel B, and panel C. Panel A is the kids under the age of 2. And the thing to note is the difference in the y-axis. It goes up by thousands, whereas in panel B and C, it sort of goes up by 10s, 5s, and 10s. So much, much bigger burden in the under 2s, a much bigger burden in the under 6 compared to the 12 to 23 months. So that's really where the RSV causes most of the disease. Down the bottom there, you can see that it has started to climb up in the over 65, and that's probably just an artifact of the fact that we're now testing in people that come into hospital with respiratory infection. So based on that, the pharmaceutical companies are targeting the under 2s and the over 65s. And the vaccine will be assessed probably by our regulator soonish. It certainly has been assessed by the FDA, and this is the over 65s, and there might well be vaccines that roll out in the US to protect against RSV soon. These are the two sort of candidates really are the Pfizer and the GSK. They're the lead ones. And the vaccine effectiveness against RSV in the adults is sort of pretty good in that 70 to 80% effective. I understand that Johnson & Johnson is no longer going to pursue that adenovirus vector vaccine. That was just made, announced a week or so ago. So yes, the RSV is the next one to appear. Just a little bit on Vaxelis. Vaxelis is a new pertussis DTP containing combination vaccine. It has the same constituents, so it has DTP, hepatitis B, Hib, and polio as Influenza hexa. It's slightly different in the pertussis component in that it has 5 different antigens, whereas Influenza hexa only has 3 different whooping cough antigens. But probably the biggest change from a proprietor's perspective is that you no longer need to reconstitute it. As you know, with Influenza hexa, you've got that little Hib pellet that you have to sort of draw up and put into to reconstitute, but you don't need to do this for Vaxelis. So PBA has assessed it and has recommended that it be included on the NIP. So we'll hear more about the recommendations about that soon, but it's certainly passed an important hurdle from their side in passing the PBAC. And then finally, a little bit on the immunisation specialist service. The bottom line is that the email is down there. We're a service that can provide advice to providers. We hope we're responsive in that you send an email and we respond within the day or within the following day. For some situations where there's a need for consultation, we can arrange for the child and family to be seen either in the clinic or via telehealth. And we do actually have a service at the hospital and where we can vaccinate adolescents and children who are difficult to immunise because of, either disability or other issues. So just to make you aware of that service, and just also to remind everyone that as clinicians if you suspect an adverse event, it is mandatory to notify them to the public health units. So just to remind folk on that one. But NSWIS service can help you with advice about is it safe to vaccinate, how to manage an adverse event, and if someone's had an adverse event, what to do with the second or third dose, etc. So I'll stop there, Kira, and happy to take some questions now or later on.
Thank you. Yeah, we've got a couple of questions at the moment. So I will start with one. If someone has had their flu vaccination in the USA in December 2022, would this person still need to have their 2023 flu vaccine here in Australia?
Yeah, I think it's probably beneficial to do that. It's probably been 4 months since by the time they get round into their clinic. It probably is worth topping that person up with Australian brand vaccine.
Yeah, excellent. And then a question on Boostrix or DTP vaccine recommendations few avenues regarding adolescents, pregnant women, adults, etc. So for the adolescents, after their Year 7 booster, when is the next booster due?
So it's certainly recommended when you're over 65 to get your a pertussis-containing booster if it's been more than 10 years. For those that are pregnant, obviously they should get one, and they should get one with each pregnancy. It sort of depends on whether you're a healthcare worker or not. They should get a pertussis-containing booster every 10 years. If you're an early childhood educator, you should also get one every 10 years. So there are many sort of permutations. It's all spelled out quite nicely in the immunisation handbook. Yeah.
Excellent. Let's just see. You mentioned that NSWIS can vaccinate children and adolescents who are difficult to vaccinate, but what about adults? Where can they go?
That's a really good question. And to be honest, we haven't got a fantastic way to handle that in New South Wales. In fact, not much of a way really in many states. I think it's probably, if that particular case, you could have a chat to us. We can probably try and arrange or help out by talking to the local hospital. But yeah, no, it's not really not a, the service could be improved, put it that way.
Yeah, I would also like to mention at this point that the PHN has a service called GROW, where we offer one-on-one training with general practitioners and nurses about dealing with patients with intellectual disability. So that kind of, comes under that, if they're a certain cohort that, need a vaccination as an adult, then they can come get the training through GROW from our end to try and help them facilitate the vaccination within the general practice. So we'll add that information as well. Another question, a person is going away overseas in 2 weeks' time and it's been 5 months since their previous COVID vaccination. Would you recommend a booster?
Yeah, so it gets back to a little bit to their past story in the fact that if they've had so they're going away, it's 5 months since their last dose, is that what you said, and more than 5 months since their last infection.
Yeah.
And I think if they were, a 25-year-old male, they probably wouldn't. But if they're a 64-year-old and they're going on a cruise ship or something, I probably would. So it's a little bit, and that's why I think the recommendation to discuss with your provider is the way that the TARGI has landed, because there are individual circumstances that can help, finesse that answer, really.
Yeah, excellent. And yeah, as well, if you ever have that situation at the time, you can always call an NSWIS for help as well.
Yeah.
With the arrival of the Moderna pre-filled syringe booster for the over 12-year-olds, would you recommend active recalls for the over 12s?
What do they mean by active recall?
So calling in the patients that might be due for vaccination with the updated VO5, 4 and 5.
Well, for the 5, what we said before, for that 5 to sort of 18 age group, if they're well, and I probably wouldn't be giving them another dose. Does that make sense? So, but if they are 5 to 18 and have risk factors, and it's been more than 6 months, yes, I would try and give them the bivalent 4-5. Yeah.
Yeah. Great. And are Pneumovax and Prevnar 13 interchangeable?
No. So Prevnar, again, on the handbook, there's a nice section about what, so the pneumococcal one basically is over 60s, I think it is. I just have to check that one, but you would be getting the Prevnar as the preferred booster for the over 60s rather than a Pneumovax. So it's 70. Sorry, I got that wrong. It's not 60, it was 70. So you should get, if you're So don't give them the 23 valent, the Pneumovax. If once they reach 70, give them the 13 valent Prevnar, or there's actually the new 15 valent Prevnar. So is that
Excellent.
making sense?
And then also if you need help with that, there's a PneumoSmart tool with the decision tree for Pneumovax vaccinations. So that can also help as well in deciding.
Yeah.
Do the current bivalent COVID vaccines provide protection against the XBB subvariants?
Yeah, the data is emerging on that, so they probably do. The company keeps chasing the variants. So the early evidence is that it does give you some protection against certainly the BA.4/5, and it probably protects you against XBB.1, but that data is not quite out. So, and I don't know if they're going to keep trying to chase the variants down to that sort of level. But yeah, I think BA.4/5 is probably the preferred one over the BA.1 bivalent.
Yep. Excellent. And why is a booster recommended in each pregnancy when it provides protection for 5 to 10 years?
Yeah, it's a great question. My answer to that is that probably what we know it does is that the pregnant woman responds to that vaccine very nicely and makes antibody within a couple of weeks. And the pertussis, we've done this from the trials, and the pertussis antibody in that pregnant woman is sort of bumped up. That larger amount of antibody that she has in her system is then crossing into the baby. So by topping up the mum every pregnancy, you're actually protecting that newborn infant in the first 2 months of life. So that's why we recommend it every pregnancy. Now, I'm hoping to do a study where we give the pregnant women the pertussis only vaccine rather than the diphtheria, tetanus, pertussis containing one. Because like you, I don't think they really need a tetanus and diphtheria boost every couple of years, particularly if they have pregnancy every 2 years, but every second year. But that's not right. We don't have that on in train now. But that's the concept, really, to boost mum's antibody level, crosses to baby, and baby's protected in that first 2 months.
Yeah, excellent. And then I just a sub question of that I just guess we can confirm again that family members of a pregnant lady, that how frequent is the booster dose needed? And that is, as you said earlier, every 10 years.
Yeah, that's right. Yeah.
Excellent. I think that is all the questions we have for now. Oh, there's one more about is Vaxilis on the NIP?
It's past the PBAC in terms of being on the NIP. I think it was recommended for listing, but then it's up to the government to actually put it on there. So PBAC says it meets cost benefit, and then we're waiting on the government to say yes, we're putting it on the on the NIP.
Yep. Excellent. Despite boosters being available for 12 years plus, do you recommend for 12 years plus with comorbidities?
Yeah, I think it gets down to, as we said before, the sort of in that 12 to 17-year-old age group. What's their underlying risk factor? How did they go with dose 1 or dose 2? Did they go well with that? If they've got sort of chronic immune problems and they went well with dose 1 and 2, and it's been more than 6 months, then, and they're worried about getting severe disease, then yes, you could give it. But yeah, that is really contextualized to that, how severe their comorbidities are.
Yeah, and I guess again it comes back to NSWIS. If you need extra consults with this, with those type of questions with specific patients, you can always contact NSWIS for that help. One more on Pneumovax. If over 65 has had 2 doses of Pneumovax, when they reach 70, do you give Prevnar?
So if they've had Pneumovax in the past, did you say?
Yeah, 2 doses of Pneumovax before, if over 65 and had, so yeah, maybe they've had 2 doses from 65 to 70 of Pneumovax. Do they still need Prevnar when they turn 70?
Yes, and it should be at least 12 months after their last pneumovax.
Yeah. Excellent. And again, that the handbook is a great resource to help you with that, and as well as the NeumoSmart tool.
And NCRS frequently asked questions are quite useful as well.
Yeah, another great resource there. Yeah. I think that is all our questions. Thank you, Nick, so much for that rapid fire.
And that's okay. No, I'll try and answer some in the Q&A block as well.
Yep, excellent. So yeah, if you have questions still coming to mind, please keep asking them, and we can always type our answers back to you as well. Great, thank you, Nick. Next up, we have Jane Frawley. She is Associate Professor in the School of Public Health within the Faculty of Health at UTS. Her primary research aims to decrease vaccine preventable diseases and support the uptake of vaccines in Australia and the Pacific region. Jane has done a large amount of research to understand the behavioural and social drivers of immunisation and provide insights to increase COVID-19 vaccine uptake. She's passionate about translating research into usable information for the public, and recently led a team of experts to develop online interactive vaccine information resources to help people make decisions about vaccine for themselves and their children. So you're doing great work, Jane. Tonight you'll be presenting on the vaccine uptake and acceptance, conversation approaches to support COVID-19 booster and influenza vaccine uptake. Thank you, Jane.
Thanks, Kira. Thank you for having me. So just before we start, I'd like to pay my respects to the Gundungurra and Durag people of the Blue Mountains, who are the traditional owners of this land, and it's the land that I live on. I feel lucky to live on this land every day and acknowledge that sovereignty has never been ceded. So tonight I'm going to quickly walk through some recent research that we did looking at parents of young children's attitudes and beliefs, and I guess information needs to the flu vaccine. And it also gives us a few hints about questions that people have, not just about their children and the flu vaccine, but about themselves as well. And talk a little bit about vaccine hesitancy, and then about having effective vaccine conversations. And then I'm going to talk about the very prickly issue of addressing misinformation. So this is the WHO Behavioural and Social Drivers of Vaccination framework, and many of you may have seen this before. As you can see, there's many factors that impact vaccine uptake, and these can be social, practical, or access issues. But tonight we're going to focus on conversations at the point of care, so at the point of a consultation or recommending a vaccine, or perhaps conversations with friends or family. So that's the pink box in the middle, that's the motivation to get a vaccine. So let's have a little bit of a look at parents' motivations or questions about childhood flu vaccine. So this is the reasons why parents didn't get a flu vaccine. Sorry, just to go back, this was a study conducted at the end of the 2021 flu season. So at the end of the year, there was a survey of 1,000 parents who had a child aged 6 months to 5 years. And part of the reason, this is a repeat study of a study that we did 2 years prior to this, and we wanted to see whether uptake had changed much since flu vaccine for this age had gone onto the NIP. So you can see there that well over 40% of parents didn't think that a flu vaccine was necessary for their child, which I think is really great to know. It didn't occur to them. It was too hard to get an appointment because of COVID. So remembering that this was, of course, a COVID year. So there was lots of reasons around that too. I didn't want to go to the GP's office, so I didn't want my child to get COVID. I meant to, but I didn't get around to it. And just under 10%, I think that's 8%, saying that they don't think that the flu vaccine is safe for children. This is a rather busy slide, but I'm just going to touch on a few things around beliefs and attitudes. So flu is a mild disease. You can see 40% of people agreed with that, and only really 30% disagreed. Flu can put young people in hospital. However, 80% of parents agreed with that. The vaccine will overload your immune system. So only 38% of parents disagreed with that, and around the same, or 33%, agreed with that. So there's a few things here you can see where there's just misinformation and I guess a misunderstanding of how the flu vaccine works. You can catch the flu from the flu vaccine. 42% of parents agreed with that, which I think is quite high. I'm sure that they also feel that way about themselves too, of course, not just in childhood. I'm worried about the side effects from the flu vaccine, nearly 50%, and natural immunity against the flu is better than the vaccine, which is, of course, hugely concerning, 40%. And really also just to say that only 30% disagreed with that statement. So there were quite, a third of people that weren't sure. In terms of where parents sought information about the flu vaccine for their child, 65% said the general practitioner, which is fantastic. A very high amount, 40%, said friends and family, which is quite common response when we ask about information sources for almost anything. We often find that friends and family are high, and they're often around that 40%. A nurse midwife, 27%, pediatrician, 25%, pharmacist, 17%. And you can see there at the lower amount on the right-hand side, so websites and parenting groups, complementary medicine practitioner, 10%, quite high, and then other internet, and not much for social media. I'm not sure that is correct. It doesn't align with other work that we've done, and it may have been the way that social media was defined in this study. The child was more, so this is the results of a logistic regression. So a child was more likely to have or to not have a vaccine. So more likely to have a vaccine with a GP recommendation, which is great news and quite consistent with what we've found in the past. So sort of 80% more likely to have a vaccine if a GP recommends it. If there's no recommendation, then 80% less likely to have the vaccine, which is a good message. If they knew of the funding, much more likely to have the vaccine. And nurse or midwife, if they were influential in the decision, more likely to have the vaccine. And if they used YouTube, so this kind of form of social media, if they had questions about their child's health and development, they were less likely, which also aligns with a lot of literature around social media channels. And YouTube is a common channel that comes up as being associated with vaccine hesitancy, but really misinformation. So for the purpose of tonight, we're going to define vaccine hesitancy as a motivational state of being conflicted about or opposed to getting vaccinated. And this includes intention and willingness. It implies that a change is in this state is possible, though, and that's really important. And this definition is from a recent WHO position paper. My clicker's not working. I'd like to talk a little bit about motivational interviewing as a way to have vaccine conversations with your patients. The research about motivational interviewing for vaccine conversations is really encouraging, and patients often want to be part of the conversation. They want skin in the game, they want to be listened to, and they want to be part of the decision-making process. And this is a way of honouring that, I guess, and including the patient in the decision-making. It's empowering for the patient, and their healthcare decisions are taken seriously as well and accepted by the practitioner. So just a quick overview, the very busy slide, but just a quick overview here of some of the core skills, I guess, of motivational interviewing. So we can think of them as ORs. So O is open-ended questions. So let the patient discuss their concerns, tell their story, tell you what they're worried about, and the patient should be talking during this time. So listening is definitely the best thing to do here. So as an example, can you tell me what worries you about the vaccine? What have you heard about the vaccine? So inviting conversation using an open-ended question rather than do you want a vaccine today? Having a kind of, are you concerned about the vaccine? Yes. So trying to kind of really open up that conversation and saying, would you like to talk about your concerns today? What are you concerned about? Acknowledging their concerns is also really important. So I can see that this really concerns you. I can see that you're really upset. I can see that this really worries you. I can see that you've got lots of questions. Would you like to discuss some of those now? Reflecting. So reflective listening includes empathy and sensitivity about the feelings that are being verbalized. So I know that you want to make the best decision for your child and that you're worried that these vaccines are safe. So just reflecting back what you've heard and then summarizing the conversation quickly. So it sounds like you're concerned about the side effects of the vaccine and the possibility that it was rushed through the approval process. Did I miss anything? So open-ended questions, acknowledging their concerns, reflecting back and showing that you've listened, and then summarizing at the end and asking if there's anything further that they'd like to add. A couple of other helpful tips. So empathize and normalize. I think this is really important and it's really easy to do. So hearing them out, listening to their concerns, and then once they've finished, normalizing their concerns and saying, yep, I absolutely understand. Lots of people have got the same concerns, or yep, this is a really unprecedented situation. It's really natural to feel this way. Goes a really long way to put that person, to disarm that person and put that person at ease. And it helps build trust, which is, of course, what we need for this conversation. So asking open-ended question, affirm the strengths that you see too. So it could be something like, down here in the yellow box, it's great that you're thinking about vaccination, or it's great that we can have this conversation today. We can continue at another time as well if you're not ready today. Whatever it is that you need to say, affirming the strengths is really important. Resist the temptation to correct the information, so to right the wrongs, to kind of jump in until you've listened to the story and empathize. Jumping in too quickly damages trust, and that's hard. Sometimes you really just want to say, okay, that's not true, or can I just explain that to you, or but absolutely don't. It is damaging. Sit, listen, and it also gives you time to think very carefully about how you're going to respond as well. Ask if you can respond to your concerns. It's a courteous thing to do. So can I offer you some information on why we give the flu vaccine to children, or can I explain why we give the hepatitis B vaccine at birth? Is really helpful. Offer the time and the space for the discussion as well. If there isn't time and space in where you are at the time, within a consultation, for example, and there really is no more time, then offer more time and space to have a follow-up discussion. Identify and reinforce motivation. So if you hear any motivating factors, then definitely use those, talk about those, identify them and reinforce. So it might be they're going traveling. It might be that they're starting school. They think maybe the child now should be vaccinated. It might be that the child has a chronic health condition and that therefore they think they probably should be vaccinated now. So really reinforcing any motivation that you hear come up in the conversation is really important. And clearly recommend vaccination as well. Make sure that you finish the conversation about by recommending vaccination. Okay, misinformation. So I think I've said that it's important to listen enough and, of course, to be respectful. No one wants to feel judged or silly. And this is often the reason why people don't want to have this conversation, because they've been shouted down in the past or dismissed, probably more likely in the past, for the concerns that they've got. So being respectful and listening is really important. But how do we do this without reinforcing them? And we know there's a lot of literature around this too, around debunking and research showing that it in fact often reinforces misinformation. So how do we have these conversations? This is a helpful way of thinking about it, thinking about how to address it. So starting off with the truth. So the first frame is also always really important. So the first thing that you say will always be remembered. So always start with the truth. So for example, it's not possible to get the flu from the flu vaccine. The flu vaccine doesn't cause flu. Acknowledge the misinformation and offer an alternative. So maybe something like, I've had a lot of people ask this question over the years. It may seem like it causes the flu. There is usually quite a bit of flu around when most people get the vaccine, and it's possible they've already been exposed to it. So acknowledge the misinformation, offer an alternative, and then repeat the truth at the end. So always finish by repeating the truth. So, however, it's not possible to get the flu from the flu vaccine. It's also really important here to remember to pick your battles. There's often things that we'll hear that are not true, but they're not really that important either. Are they going to impact on the decision making or an action from that person? Then if they are, then it's probably worth addressing. But if not, pick your battles. This is a rather horrifying slide, but it's just to show that as long as we've had vaccines, we've had vaccine fear and vaccine rejection. This is Edward Jenner and his mates. Actually, Edward Jenner's not quite there. I think he's around the corner. On the left there, chasing away the anti-vax establishment. And you can see all these horrible pictures of babies dying in the foreground there, through to people turning into cows and all sorts of stuff. So it is human. It's very humane. It's a very human thing to have fears around something like a vaccine. It will always be the case. I think it's really important to think about how many people are really, reject vaccines and absolutely under no circumstances would have a vaccine. Is actually quite a tiny percentage, and it seems really inflated at the moment, I think, because of COVID and because of the marches that we've seen and because of lots of stuff that's happened, and lots of ways that vaccine fears have been conflated with other fears and concerns in Australia and around the world. But really, when we're talking about especially childhood vaccines, it really is a very small amount of people that absolutely refuse. However, of the number of parents that haven't vaccinated their children, the vast majority of them are unsure. They're not sure. They're afraid to do the wrong thing. They've heard this or that from friends, from family. They've heard a story. They're influenced by someone or something, and they want to talk about it and they want to be reassured. So don't underestimate the power of those conversations. They're really, really important. And it may not happen after one conversation either. It might take multiple conversations. So a few opportunities. Ask, what are you concerned about? Would you like to talk about that today? Support parents' information needs. So if they're looking for information, they often are, then good quality sources of information. Always recommend vaccination. So be opportunistic is really important as well. So the child may have come for something jammed and it's here. Checking about the flu vaccine, it's a really good time, a really good opportunity. Recommend good online information. We know that parents are looking online for information about vaccines. So and there's lots of great ones. Kira will send around a list of them after this presentation tonight. So recommending really good online information resources is important, and always remember to keep vaccine conversations open to foster trust. Thank you very much.
Thank you, Jane. I hope that gave everybody a bit to think about when you have these interactions with your patients. And yeah, if you have more questions, there's learning modules out there and resources galore. And we're also looking at doing another session, a lunch and learn session on vaccine hesitancy with Jane. So that's coming up in May. So keep your eyes peeled on the Sydney Health Weekly to register for that. And that one will hope to have some submissions from, live scenarios that have happened in the past that, how can we look at this better? So yeah, it'd be a good time to, go over individual scenarios and cases. So thanks again, Jane. That was lovely.
Pleasure.
Next up, we've got Vicky. Hello, Vicky. Welcome, Dr. Vicky Sheppeard. She'll be providing an update on the Public Health Unit, overview of the role of the Public Health Unit, mandatory disease notification, emerging diseases, and rabies-prone wounds. Vicky Sheppeard is a public health physician who has been working for New South Wales Health since 1999. Vicky's current role is the Director of the South Eastern Sydney Public Health Unit, and she's a member of the TGA's Advisory Committee on Vaccines. From 2013 to 2019, Vicky was the Director of the Communicable Diseases Branch, Health Protection New South Wales. This role included overseeing surveillance of notifiable diseases in New South Wales, coordinating communicable disease control activities, oversight of the immunisation program, including the delivery of school-based adolescent vaccination program as well. And also from July 2017 to June 2019, Vicky was the chair of the Communicable Disease Network of Australia. So thank you, Vicky, for joining us tonight.
Thanks, Kira. Pleasure to be here. And so, yeah, I've got quite a lot to cover in 15 minutes, so I'll get right onto it. So these are the things you've asked me to talk about: the role of the Public Health Unit, mandatory disease notification, some emerging diseases, plus the recent updates to the immunisation schedule, and last but not least, managing rabies-prone wounds. There's two public health units covered by CESPHN. One is Sydney Local Health District, and I'm from Southeastern Sydney Local Health District. In Southeast Sydney, we have around about 32 staff, and we've got an admin team who kindly answers your calls when you call us. We have environmental health, we have infectious diseases and immunisation, an epidemiology team, and a medical team. And luckily for us, most of those things have grown thanks to COVID and, well, as a result of COVID. And look, we don't have a lot of time to go through it in any depth, and very similar arrangements in Sydney Local Health District, and the link to their website will be provided after the webinar tonight. We have, it's a very broad range of things we cover, and we try to keep as much information as possible on our website. So the immunisation section has many of the details of the things we've been covering tonight, including vaccine accounts, school program, etc. Environmental health is very broad, and you may not be aware of as much as what we do in environmental health, but the team there look at Legionella control and investigations. They do legal tobacco, any cigarette control work. We have Aboriginal environmental health activities, mosquito control. We trap mosquitoes around the district to see if there's the amount of mosquitoes and if they're carrying arboviruses. Respond to environmental hazards such as the, for example, the diesel spill in Cornell last year. We test and monitor swimming pools to make sure they're safe, investigate breaches of skin penetration in places like beauticians and tattooists. Funeral industry, including authorization of medical referees for cremation, and water quality. So that's a very, very broad portfolio. We have a section on our website of hot topics where all the recent alerts are posted. We've got information for aged care, childcare. We have our Aboriginal support team. We have our epidemiology section where all the local data is posted. For example, we post a weekly report on acute respiratory infections, COVID, flu, and RSV in the district. We also have our immunisation coverage there, the Mozzie surveillance, and our STI reports, which are done 6 monthly. And then the final thing we do, which is a little bit unusual, is the cruise ship program. So that's we we monitor incoming outbreaks and do inspections of cruise ships. So that's a special function that we have in Southeastern Sydney Public Health Unit. So on to disease notification. So this is a requirement under the Public Health Act. And there's a link again in the resources for the conditions that are notifiable by doctors. So obviously that includes GPs. And these are conditions which are supposed to be notified to us by phone. So I'd really point out here, measles is something that we'd like you to call us about. Suspected measles, not waiting until a lab test is done if you do think someone has measles. Monkeypox is also on that list. And then things that are hopefully less likely to be encountered, viral hemorrhagic fever, smallpox, SARS and MERS, but also foodborne illness and gastroenteritis in an institution are also notifiable by phone. And the reason for that is so that the Public Health Unit can give you advice on testing and also start with the public health response as soon as possible. I'll just note that there's many more conditions that laboratories notify us of, for example, influenza, whooping cough, diphtheria, etc. While they're not notifiable by doctors, the Act does require doctors to provide more information to the Public Health Unit if we do call to find out more information to enable the follow-up public health action to occur. All right, so on to emerging diseases. So the first one that I'll address is Mpox, which is, I beg pardon, sorry, I've inadvertently changed screens there. So Mpox, as you'll all be aware, and we did have a webinar on this last year, it emerged as a global health threat in May 2022, and the graph you see here is the daily confirmed global cases as reported to the World Health Organization. So we can see that around about August, this outbreak peaked with over 1,000 cases notified per day. And it has now tailed off to a great extent this year, but there are still cases being notified in some countries. Throughout this outbreak, it's mainly affected men who have sex with men and people who have close contact with men who have sex with men. So that's in total about 87,000 cases with 112 confirmed deaths. In New South Wales, while the epidemic curve is following a similar pattern to what was seen globally, the numbers are far fewer. So we've only had 56 cases, and we've had no cases since last November, which we're very pleased to see. 48 of those cases, so the vast majority, have been in southeastern Sydney or Sydney local health districts. And all cases have occurred in men who have sex with men, 50 of which were overseas acquired, so just 6 locally acquired cases. Just 5 of the cases had to be hospitalised, 2 for pain management, 2 because they had eye involvement, and 1 for the rash, and they all recovered. And, you know, while we don't have the data to hand yet, I think that part of the reason for the successful suppression of Mpox in New South Wales was a very successful rollout of the Jynneos vaccine program, which started off, it was around about October, and first targeting the very highest risk groups, and then eventually made available to all MSM and others at risk of contact, often with infrequent contact, close contact with MSM. So that's, I think, been very successful in reducing the risk of Mpox cases in New South Wales. We still need to be on the lookout, but for now, it's going very well. The next thing I'd just like to mention is serious mosquito-borne infections. And while Japanese encephalitis is top of mind because that was first discovered in southeastern Australia in 2022, this season there's a very considerable risk from not only Japanese encephalitis but also Murray Valley encephalitis and Kunjun virus. So these are all very similar. They're flaviviruses and they can all cause encephalitis. And if you pick a point in New South Wales starting about Albury and go straight north, most places west of there have where we do monitor for mosquitoes or sentinel chickenpox, etc. Most of those major communities have had one or more of those viruses detected this year. So it's very, very widespread, and we haven't seen a risk like this for many years. The Japanese encephalitis can be prevented by vaccination, but there is no vaccine available for Murray Valley or Kunjun virus. So there is Japanese encephalitis funded vaccine available, but that's only for people who live or routinely work in affected LGAs. And I'd like to suggest that most of the residents of Sydney and southeastern Sydney, we wouldn't be recommending vaccination if people were travelling to those areas. The most important thing is to educate them about avoiding mosquito bites. So there's a few things we're recommending. Spray up, so that's regularly applying an effective insect repellent. So that's not a herbal insect repellent, that's one that contains DEET or oil of lemon eucalyptus. Wearing light-coloured and loose-fitting pants and long sleeves, and having accommodation that has effective mosquito screens or netting. And I'd probably add that giving a Japanese encephalitis vaccine to a person travelling to that area might actually make them complacent. So in fact, there's a lot more Murray Valley encephalitis around than Japanese encephalitis. So the main thing for travellers from this district out to Western New South Wales is to take those 3 steps to avoid mozzie bites. So if people do present to you after a trip to Western New South Wales, a few things to keep in mind. Less than 1% of people who are infected with these viruses experience clinical disease. The incubation period's 1 to 2 weeks after the bite. Of those who do experience clinical disease, so that's the 1%, most are just a mild fever, headache, myalgia, rash and diarrhea. But the severe disease presents as acute meningoencephalitis, and they should be referred to the emergency department for investigation. If your patient has a mild suspected infection, so if they've travelled and 1 to 2 weeks to the Western New South Wales or Southeast Queensland or Victoria, 1 to 2 weeks later they have the mild symptoms, fever, headache, myalgia, rash and diarrhea, you can collect serum and request antibodies for flaviviruses, Japanese encephalitis, Murray Valley and Kunjun, IgG, IgM and total antibody. And if possible, collect a blood and urine for PCR. And the link to the latest advice is also on the resources page data for you. Moving on to measles, and this very evening we have a suspected measles case in the district, following on from a case that was in Parramatta just about a week ago. So unfortunately at the moment, measles outbreaks are very widespread in much of the world, and particularly in those parts of the world frequented by Australian travellers such as India, Indonesia, Pakistan and South Africa. Anyone who's not fully vaccinated against measles is at risk of importing measles to Australia. And yes, we have had recently detected cases in New South Wales, Victoria and South Australia. So as a GP, if you do have the opportunity to do a pre-travel assessment for anyone up to the age of 57, check that they have had 2 doses of MMR during their lifetime, or measles-containing vaccine. And if they don't have 2 documented doses, they're eligible for a free vaccine, MMR, before they travel. And very importantly, families taking infants between 6 and 12 months of age to high-risk countries such as India or Pakistan, you should recommend a dose of MMR for that infant before travel. That won't count towards their fully vaccinated. They'll still need to receive 2 more doses of MMR after 12 months of age, but that is a good step towards protecting that infant during their travel. And then in returning travellers, so remember, measles has an incubation period up to 3 weeks, and people presenting with fever, runny nose, sore eyes and a cough. Make sure the person's isolated. By all means, call the public health unit for advice on testing. We will likely recommend both blood for a PCR and serology, and a urine for PCR. All right, the latest New South Wales immunisation schedule. Important to note that that has been updated in March 2023. I think the really key things to note, not so much an update, but just like to emphasise the meningococcal B vaccine that's available for Aboriginal children at 6 weeks, 4 months and 12 months of age. And the catch-up for that is still available for children, Aboriginal children up to 2 years of age. And that catch-up's active until the end of June this year. So really good thing to offer your Aboriginal patients, and also to remember to ask about Aboriginal status for all your patients so that they can be offered the additional vaccines that they're recommended. Not new information, but just a new way to present the schedule to emphasise where annual influenza vaccines recommended. So at those childhood points of 6 months, 12 months, 18 months and 4 years, whenever you see children. And then I think another good feature of the new schedule is that there's a section there for at-risk groups. So in particular, the vaccines that people with asplenia, complement deficiency, the vaccines that those high-risk groups are eligible for under the National Immunisation Program. So those are meningococcal and Hib vaccines. And then finally, a reminder about the change in the HPV schedule, which we're offering to children in Year 7. So it's just now 1 dose is considered fully vaccinated for HPV, and there's catch-up available for people up to 26 years of age who've not ever received an HPV dose. And just another reminder about the additional vaccines that are available in New South Wales for free. So in particular, hepatitis B for Aboriginal people, contacts of hepatitis B cases, men who have sex with men, injecting drug users, sex workers, immunosuppressed people, people with HIV or Hep C, or clients of sexual health clinics are all available for free hepatitis B course. As I've already said, the MMR vaccine is available for anyone who doesn't have anyone over 12 months of age who doesn't have 2 documented doses of MMR, of measles-containing vaccine, and also for those seronegative women who don't have evidence of rubella immunity. They are eligible for a free dose of MMR after their pregnancy is completed. And then really importantly, and very much running out of time, we have free rabies vaccine and rabies immunoglobulin for post-exposure treatment. So responding to rabies-prone bites. So while in Australia, we only have a risk of rabies from bats, in many countries of the world, terrestrial mammals, e.g. dogs, but also cats, ferrets and other mammals are commonly found to carry rabies. Noting on this map, while the US is in yellow, there has been quite an increase in mammals, on ground mammals, such as coyotes and other things that are now carrying rabies in the US. So the risk in the US is perhaps a little higher than indicated on this WHO map, which is a little out of date. But particularly Asia, Southeast Asia and Africa are places with very high risk of encountering a mammal that carries rabies. So we've recently worked to update the rabies pathway on the health pathways, and there's one on both Sydney and Southeast Sydney websites. So I'd encourage you to follow the advice on that health pathway. But the important key things are the initial management includes thorough washing for at least 5 minutes with soap and water of a bite or a scratch from a mammal. And then application of virucidal solution, probably povidone iodine is the one that's on hand and can be used. And then the thing is to call the public health unit for a risk assessment. And depending on that risk assessment, we can supply rabies immunoglobulin and the course of vaccine that's required for the type of bite or wound. So here's our contact details. We're still open 8:30 to 8:30 Monday to Friday, but we have on-call nurses and staff specialists via Prince of Wales Switch on the weekend, and similar arrangements at Sydney Local Health District. And we also have emails for our infectious disease and immunisation teams there that you're always very welcome to reach us on. Thank you.
Thank you, Vicky. Some great information there and good reminders for people working in general practice. So thanks a lot. We do have a couple of questions and I will just touch on, thank you, Nick, to answering some as well. One, is the catch-up schedule for HPV still 3 doses?
No, if anyone's had 1 dose of HPV vaccine, they're now considered fully, well, depends. Again, it's a complicated one, depends on what age they received it. If they received that vaccine under the age of 15 years, they're considered fully vaccinated. If they're immunosuppressed or started their course after that, then it will be different, but that is all in the handbook.
Yes, indeed. And then is the MMR free for eligible patients, including those without a Medicare card?
Don't tell anyone I said this, but yes, we'd prefer that we had fully vaccinated people living in New South Wales, irrespective of their Medicare card. So you can blame me.
Vaccinate away, yes. If a woman of childbearing age who works in an occupation that puts her at high risk of measles had 2 doses of MMR but is seronegative, would she need a booster?
Yeah, I'm happy for Nick to chime in here. I think not. If there's 2 documented doses of MMR vaccine, then we wouldn't be recommending any further doses, and it's highly likely that if challenged by exposure, that the person would still mount a good response.
Yep. And yeah, there's more information in the handbook on that too, I think. There is one more question. How do I reassure a 25-year-old patient that 3 doses is not required? I'm assuming this is in terms of the HPV. They are asking if they will get optimal protection.
Yes, so if this is someone who's, it once again depends when they started their course. And probably I'd have to refer to the handbook to make sure that I got the right information. I don't know if Nick wants to chime in there.
Sorry, Vicky and Kira, I was just trying to look up. There's a section in the handbook which I'll put on about the MMR one, about exactly as you said, Vicky, if they had 2 previous MMRs and seronegative for rubella, then does not need another one. And so this was about
how do I reassure a 25-year-old patient that they don't need the 3 doses of
and had
HPV.
any doses, or do we know if they've had any doses? Or
I'm
not sure?
assuming one or two doses, whatever's been recommended.
Yeah. So look, these are based on long-term follow-up studies. And WHO now recommends that a single dose is very, very good protection, particularly against, cervical cancer, which is the main goal. So, there's again, the FAQs on NCERS will provide some, there's a couple of links there that will help about that one dose schedule being the preferred one. So we can reassure and perhaps direct them to the FAQs. It might help.
Yeah, lots of data out there to support. What about if measles serology is negative after 2 doses and there's exposure to measles in pregnancy, do we need to give immunoglobulin?
That's a good one. I think I'd be talking to the ID team at the local hospital. I don't know, Vicky, what you recommend. There is an algorithm on the NCERS website. I'll try and put the link in the chat about that one.
Yeah, we can also add it to the resource sheet we'll provide after. One last one on Hep B. After taking adult Hep B, vax serology is still less than 10. What advice should we give?
Me or Vicky, or so
taking adult Hep B vaccination, and then after that serology is still less than 10. What advice should we give?
It depends a bit on the previous doses, the time that the serology was taken. The handbook, so if it was taken, 1 month after the 3rd dose, so the best time if they're getting a 3-dose course, and that's less than 10, then they have been a non-responder. A little bit depends on what their sort of background risk is for Hep B, but there are options including double doses like dialysis dose Hep B or even intradermal, and so there is a section in the handbook that talks to that as well. So it really depends a bit on, do they need to show it because they're a healthcare worker or police or etc. But if they're a routine citizen and they've had 3 doses, I just leave it at that.
Yeah, excellent. Yeah, I think, Vicky, we lost you there for a moment, but you're back. I think we might leave it at that. We did have a little presentation on Brooke on just what we can support you with from the PHN perspective, but we'll just add that into the email at the end that you'll receive afterwards. I would like to thank all our speakers tonight. We've had fruitful discussion within the Q&A, and I guess as well, just, whenever you come across a question that you can't find the answer to, review the handbook, review information on our websites, always contact us as a first point of call. If we still can't help you, if it's a clinical question, we would refer to the public health unit, and then there's also the NSWIS team at the end of the line. So, when you come across specific scenarios, there is always someone to ask, and just keep in mind those resources. Great, thank you everybody. Hope you have a lovely evening. See you next time.
Thanks, Kira.